breast imaging radiologist and assistant professor, Anderson Cancer Center in Houston, Texas. She completed her medical degree and diagnostic radiology residency at Duke University in North Carolina. She joined MD Anderson for a fellowship in breast imaging before becoming a member of faculty. Her research interests include global health imaging, radiology education, and implementation of novel breast imaging techniques into practice. She has authored numerous peer-reviewed papers in radiology. She will talk about preoperative breast localization technique. We would love to hear from you. Dr. Omofoye, please.
Thank you, everyone, for the invitation and the opportunity to meet with you all. It's an amazing group. I've been hearing of some of the wonderful things you're doing for breast cancer in Bangladesh, and it's truly an honor to talk with you all during this Breast Cancer Awareness Month. So welcome, and I should say good evening to you, since it's evening time for you, even though it's still morning for us. So thank you for the opportunity. I agree that I love interaction. So if you have any questions, please feel free to enter them in the chat box. And at the end of the presentation, we will have a chance to go through some of those questions and hopefully answer them to your satisfaction. Are you all able to see my screen?
Yes, it's visible.
Yes.
Thank you. So this morning I will be talking about advances in preoperative localization of breast lesions. We will be talking about some of the different techniques for localizing breast lesions and how to decide on which technique. I have no disclosures of relevance. My objectives for today, I will be discussing the benefits and drawbacks of traditional wire localization. I'll discuss various localization devices and how to decide what is the best device for localization of non-palpable masses. Just by a wave of hands, a show of hands, how many people are using wire localization versus other kinds of localization? Is everyone performing some sort of localization technique? Some nods, maybe, yes, okay. So essentially what we're trying to accomplish in localizing masses is going after masses that are too small to be felt and placing a device within the mass or within that lesion to help a surgeon remove just that lesion as part of a lumpectomy or segmental mastectomy without having to remove the entire breast. We localize masses that are non-palpable, whether they are benign masses. Sometimes if it's a benign mass that's causing pain, or if it's a benign mass that's showing to be growing, we will localize that. If it's a mass that is high risk or a lesion that is high risk, for example, a papilloma containing some atypia or a radial scar containing some atypia. Also for masses that are malignant, certainly we will localize that. Malignancies are often localized if they're very small, so if they were detected on screening mammography and so are maybe smaller than 2 centimeters and not able to be felt by the surgeon, or sometimes after a patient has had neoadjuvant chemotherapy treatment, then they are able to shrink that tumor small enough that it's no longer palpable, and then we will perform localization of that lesion. Certainly, sometimes we also localize lesions that have not been biopsied. So if a lesion is not amenable to percutaneous biopsy, perhaps it's very, very close to the chest wall, we will sometimes perform a localization of that to help a surgeon remove it. What we're trying to do in the localization is to help the surgeon remove the area of interest, but reduce the amount of non-target tissue that gets removed. So every localization procedure works in the same way. And this is going to be true regardless of what kind of device you're using. So prior to the procedure, the radiologist has to review all of the relevant imaging and pathology. For example, if you have received a report that this patient needs a localization, you have to look through all of their breast imaging history to see if, you know, how many areas need to be localized, because sometimes it's more than one or one in each breast. Sometimes they may have other areas that still have questions. So let's say, for example, they had an ultrasound guided biopsy showing a malignancy that needs to be removed, but they have calcifications on the mammogram that were suspicious and have yet to be biopsied. It's important as a radiologist to make sure that that biopsy occurs before a localization is performed. It would be important to make sure that all of the open questions about the patient's breast imaging history has been answered before we perform a localization. When reviewing the patient's breast imaging and their pathology, we want to also look at what would be the best modality to guide the localization. Ultrasound tends to be our preference to guide breast imaging localization because it's the most comfortable for the patient. They're able to just lie on their back. It takes the shortest amount of time, and it gives you a lot of flexibility in your approach. We also are able to perform localizations using mammography, using tomosynthesis, and very, very rarely we'll perform them with CT or MRI. But our preferences more commonly tends to be ultrasound and then mammography. When selecting how to perform that localization, it's going to be important to select the appropriate device type. If you're using a traditional wire for localization versus some of the other techniques I'll talk about today, like the radar reflectors or the radioactive seed or the tags. It's also important to determine the number you will use. So at our institution, most of the surgeons prefer that if a lesion is greater than 2 centimeters, we start to use 2 wires. So we will localize something that's 1 centimeter, but for example, were you to have calcifications, such as DCIS calcifications that span about 4 or 5 centimeters, we would place a device to localize the anterior portion and the posterior portion so that the surgeon then takes the area in between the 2 wires in a bracket. So selecting your device type, your device number, and then the length. So using your imaging, if you have chosen to perform a localization using ultrasound, then you look at the ultrasound images and you measure the distance from the device, from the skin to the area of concern, and you want the shortest distance. So if the depth from the skin to that mass is only about 2 centimeters, then you know that you can use a device that is 3 centimeters long. If the distance from the skin to that mass at the shortest distance is about 6 centimeters, then you're obligated to use a 7 centimeter localizing device. On mammography, when performing mammographic localization, we essentially do the same thing. We look at our CC view and our true lateral view. And then looking at those views, we will measure the distance from the abnormality to the skin. So you measure the distance either to the lateral skin, to the medial skin, to the superior skin, and to the inferior skin. And we'll typically go for the shortest distance. And that's the length that we will use to approach the localization. For every patient for whom we're performing a localization procedure, we always obtain informed consent. We explain to the patient what we're doing, we tell them the risks and the benefits, and then we invite them to ask any questions so that we can make them comfortable and make them partners in their care. We will also then place a localization device by whatever method we have chosen, and then we will perform a post-procedural mammogram in 2 views, as well as documentation, either in your PACS system, written, or by a conversation with the surgeon. And then after the procedure has been performed, we will also then perform a specimen radiograph and examine that the device was removed and the area of concern was removed. So there are very many localization options. The wire is the most common option for localization. We have been using the wires in some form since 1979. And there's been different kinds of wires that have been created in that time. And I'll talk a little bit briefly about some of those different kinds of wires. There are also radar reflectors, the Scout reflector, which is actually the most common device that I use now at my institution. And I'll share the benefits of each of these. We also have the option of using radioactive or magnetic seeds or radio frequency identification tags. So here's an example of localization needle types. There's basically 2 broad types of localization devices. It's either that somebody would use a repositionable device, such as a Homer or a Hawkins device, or that they would use a device. Oh, I'm so sorry, excuse me, my screen is acting funny here. I'll go back to. There we go. So it's a choice to use a repositionable device or a non-repositionable device. In looking at the repositionable device, you can see that it's the end of it that's coming out of the needle on the end is actually curved. It's able to basically be retracted into the needle or advanced out of the needle into the tissue. So it kind of can go in or out of the tissue. And so that is repositionable. And when you place a repositionable device in the breast, because that device is so flexible, we typically can place it we'll typically place it while the device is still in the needle. So you move this entire contraction into the breast as one unit. And then once you are at the position that you want, you can then advance the more curved portion into the breast. The issue with the repositionable devices is that there is more risk of that wire leaving the position that you need it to be in. If it gets jostled, if the patient does not follow instructions properly, or sometimes even in the process of the surgery, as the surgeon is manipulating the breast tissue, sometimes that needle can get moved from the exact position that you want it to be in. So we rarely use the repositionable. We more commonly will use the non-repositionable device. For example, the Copens, which you can see on the end of it is a very sharp hook. So when we're placing this, we completely separate out the needle from the wire inside of it. We get the needle into the perfect position, and then through the needle as a guide, we'll place in the wire, remove the needle completely, and you give just gentle pressure on the wire just to make sure that it does not come back on you. So we give a little gentle pressure, we lock that hook tip into place, and that wire by itself stays in the breast. So when we perform an ultrasound guided needle localization, for example, then one of the things that we're going to do is you'll see, we'll image the mass. So here, this is a mass that had been previously biopsied. This is the clip within the mass. And so what we will do then is that we will then take our ruler and just measure, this is on your PACS system, and we'll just measure the distance from where we would like the hook of the wire to be all the way to the skin. And in this case, it was about 3 centimeters. And so we placed in, here you can see, this is the needle placed in, and then through it, here's the thinner wire with the hook. So you can then remove your needle and the hook is left in place. We typically then will give the surgeon a distance of the skin depth. So, the surgeon can see the wire sticking out of the skin here, and we'll tell them that there's a distance from where the wire is coming out of the skin to where the wire is superimposed over the mass. And we'll say maybe this is about 2 cm. And then we'll also tell them the depth of the mass below the skin, and which in this case was about 1.3 centimeters. And so this helps the surgeon when they're seeing that lesion to be able to identify, exactly where their area of interest is. This is a mammogram guided localization. In this case, you see on this lateral view, there was actually a biopsy marking device at this location. So once we've decided that the closest distance to that lesion from the skin is the medial view, then we place the patient in the medial view using our paddle on the mammogram. And with this open paddle, we can look at the grid and see the location of that needle device, of the biopsy marking device. In this case would have been about E and 8. So when you place your needle, you're always placing, and I'm saying this for the residents who may not be familiar with this, you're trying to place your needle so that the bevel of your needle overlaps the crosshairs so that you're going to place it right over the area of interest, in this case, the marker. And then you take the patient out of that medial lateral view, switch them to the orthogonal view. And here in the orthogonal view, you can then deploy the wire, which is now has the thick portion of the wire is next to the clip. When the patient goes to the operating room, you'll see that they'll remove the wire, along with it the clip and the surrounding tissue. When we communicate with our surgeons prior to surgery, we give them the same thing as we do on the ultrasound view. We'll tell them the distance from the skin to that lesion, the length of the lesion that we used, and we'll tell them typically what was localized. Did we just localize a clip? Did we localize calcifications or a mass or some such thing? And then during the surgery, when the patient has had that area removed, a specimen radiograph will be taken while the patient is still in the operating room, and we will take a look at that specimen radiograph to make sure that all of the wire was removed and the wire was not accidentally cut, that the clip in concern was removed, and that the calcifications, mass, or other abnormality was removed as well. And if there are any margins that seem to be involved with the area of concern that look close on the specimen radiograph, we can encourage the surgeon to take more tissue around that margin. So here's an example. One of the things that we do sometimes with the wire localization, like I talked about, is sometimes we can bracket a lesion. So in this case, this patient had calcifications. There's an anterior clip and a posterior clip. And we localize the anterior clip and we localize the posterior clip. And so by putting the wires, one right adjacent to the anterior clip and one adjacent to the posterior clip, it allows the surgeon to take the tissue between these markers. And so the surgeon took the adjacent tissue and you're able to bracket it. So here's some of the advantages of wire localization. First of all, because we typically will put the introducer in before we lock the wire itself in place, that introducer can be repositioned to make sure it's in the appropriate location. There is no restriction on the minimal distance between wires and the bracket. There's a variety of needle lengths available. You can use a 3 centimeter needle, 5 centimeter needle, 7 centimeter, 10, 12, or 15 centimeter needle to localize your area of concern. The distal end typically anchors the wire in place and usually will not move. And so it can be a very secure form of localization. And at the end of the procedure, there's 4 to 6 centimeters of wire extending from the skin. So there's a very obvious area for the surgeon to track down to be able to go into the breast and get that area removed. So wire localization, in summary, is very effective. It is inexpensive. It gives clear surgical margins, according to research, in 70 to 87% of the time. It is able to help us get the area of interest with clear surgical margins a very high percentage of the time. So it's very effective. It's most of the surgeons are very comfortable with it because they have a clear visual of where they're trying to go, and they're able to see when they remove that specimen, they can see the wire has been removed in comfort, in totality, and so they're comfortable with it. It's often how they've trained. There are some disadvantages to wire localization, unfortunately. Logistically, it's quite inefficient. So when a patient is to have a wire localization, It means that their surgery has to be scheduled on the exact same day as the wire localization. So they have to have an appointment both with the radiology department that morning and with the operating room that same day. And then there has to be a slot saved at the end of the radiology appointment for that day so that we can do an x-ray of the specimen and get a specimen radiograph. And so there's a sort of logistical inefficiency because we have to wait to make sure that all of these schedules of radiology and surgery, as well as the patient's own personal schedule, are in alignment to make sure that this is a procedure we can perform. Because that needle is placed so far away from the area of concern and has to come in at this angle, a lot of non-target tissue ends up getting removed. So it makes for a larger specimen sample. There is a risk of wire transection in the operating room because a lot of the wires are quite thin. So it's possible for the surgical knife to cut that wire in the operating room, which creates a mess because you have to make sure you remove all of these fragments. Wire migration is also something that happens rarely with these wire localizations. Sometimes it's been reported that if a localization is done very close to the pectoralis muscle, sometimes the wire can get pulled into the pectoralis muscle and actually travel. We've seen this case reports of that happening in the axilla as well, where the length of wire that was supposed to be sticking out of the skin ends up becoming very short. The entire wire gets pulled in and migrates from the position that you'd initially placed it in. And certainly the same thing is also true with patients with large breasts. Sometimes with very large breasts, you put them in compression to place that wire and you place the wire in the appropriate position, but then after the wire has been locked in place and the compression is released, sometimes that release, that accordion effect can pull the wire further into the breast. And so you may end up with no wire at all sticking out of the breast, depending on how thick the breast tissue is. So it becomes a tricky surgical situation. Also, the patients have to be very compliant because now they have part of a wire in their breast, part of a wire sticking out of their breast. So the patient has to be very compliant not to engage in too much movement, not to pull on that wire. It has to all be secured in place until the time of surgery. And the surgery has to happen the same day to have that removed. So we reduce the risk of that wire getting cut or of infection or such abnormalities. There's also a risk of syncope with placing localization devices. While most of the data on syncope has been described with wire localizations, I think this is a disadvantage really, it's a risk with all breast localization procedures. Sometimes when the patient is sitting there or they look down and they see there's a wire sticking out of their skin, sometimes some patients will faint either during the procedure being performed in the radiology suites or before the operating room. So that is a risk that happens from time to time. So we'll talk about some non-wire techniques. And now that you know the disadvantages of the wire localization, you can see why people have been doing so much innovation of non-wire techniques. So we'll talk about the radioactive seeds, the radar reflectors, for example, Savvy Scout, the magnetic seed markers, and then the RFID tags. So there's some advantages of non-wire localization, and the advantages are true for all of these. There's scheduling flexibility. Because these non-wire localization devices are placed completely within the breast, almost like a biopsy marking clip, they're completely contained in the breast. There's nothing outside of the skin. They can be placed several days before their surgery. They don't have to be placed on the same day. So it allows the radiologists to schedule it on a day that works for them, and then the operating room can schedule at a time and a date that works for them as well. We also see that there's removal of less non-target tissue. Here, if the device is sitting in the center of the breast, the surgeon is not having to come all the way, cutting all the way around a wire to get to that device. They really can just localize to where the device is and just take a circle around it at that point. The position tends to be more secure without a risk of the wire being removed prior to surgery. And there tends to be improved cosmesis, both because you're removing less non-target tissue and because the surgeon can kind of plan the size and the shape of the specimen that they choose to take out without being limited by the position that the wire is in. They also can be helpful for target axillary node dissection. You can then easily place one of these devices into an axillary node that is suspicious, and it allows the surgeon to make sure they take out that lymph node, almost like a sentinel lymph node biopsy at the time of the axillary node dissection. And that's much safer to do than placing a wire into the axilla, which would be very scary to do because the blood vessels are right there and the wire would be sticking out and more than likely would get dislodged. So the non-wire localization really allows target axillary nodal dissection. This is one thing that we did when we were first practicing transitioning from wire localization to the radar reflector, in this case the Savvy Scout, is that we placed the Savvy Scout as per usual and then placed a wire as well. So the surgeon got to practice removing the Savvy Scout, but had the wire present for backup as a way so that they were comfortable that if they could not find the Savvy Scout, they could still perform their usual surgical removal technique. Non-wire techniques, non-wire localization techniques have many components. They basically all have three components. First, they all use a single-use preloaded 5 to 12 millimeter device. So the devices are very, very tiny that come preloaded in introducers, similar to a biopsy marking clip. There's always a console with send and receive technology, and then there's a probe in the OR to detect the device that's been placed. So here's an example of the Savvy Scout's components. So this is the console that's turned on. It's attached to this probe. It's attached to this probe that then allows the surgeon in the operating room and even the radiologist to detect the device prior to the device being placed in the breast. And here is the preloaded needle that contains the Savvy device, technically, that's sitting right about here. And so these three components are true basically of all the different wire localization techniques. And they have different methods. For the Savvy Scout, for example, there's an audible signal. So when we have deployed this Savvy Scout out of this needle into the breast and we have removed the needle, at this point the breast has nothing sticking out of it. You place the probe on the breast and you get an audible signal that beeps to tell you that that device is in place. It's been localized, and this is the same device that's used by the surgeons then when they enter the operating room to locate that device. The Savvy Scout radar reflectors are about 12 millimeters long and they're preloaded. The console makes an audible signal. There is minimal signal void on MRI. There's no radioactivity associated with this device, and long-term implantation can be performed. So for some cases, if it's known that this is a cancer, it's basically a BSRI lesion, it's highly suspicious at the time of biopsy, it is possible to just go ahead and place a Savvy device at the time of biopsy. And eventually that device will then be removed. Even if they went through neoadjuvant chemotherapy, that Savvy device will already be in place. And whenever the surgeon is ready to perform surgery, they're able to go ahead and perform surgery without having to reschedule localization in radiology. There are some limitations of this reflector. If it is placed in a hematoma, for some reason that obstructs the audible signal, and so it becomes very difficult to detect in the operating room. So you have to be careful. If some area was biopsied and there was a very large resulting hematoma, that's not a good candidate for placing a Savvy Scout reflector device. Some patients will describe an allergy to nitinol, which is the material that this device is made out of. And so they would not be candidates for this radar reflector. Also, halogen lights in the operating room can sometimes cause some interaction with the signal from the Savvy Scout technology and make it difficult to detect the technology. But I'll admit this has happened very, very rarely. The other concern I would add about this is that these radar reflectors, according to the manufacturers, should not be placed more than 6 centimeters deep. So if you have a very large breast and a abnormality that's very deep in the breast, deeper than 6 centimeters, it may not be a good area for Savvy Scout to be placed, because if it's too deep, then the surgeons may not be able to hear that signal coming out of the breast. Although in reality, what happens is the surgeon can typically, manipulate the breast tissue to reduce the amount of overlapping breast tissue to find the lesion. So here's an example. So this is a mass that was biopsied, proven to be a cancer. There's a clip in place. And then what we did is similar to how you would perform a biopsy. You insert the Savvy Scout device. You go past the center of your lesion by about 6 millimeters. And then you will then unsheath that Savvy Scout radar reflector, so that reflector is now sitting within your mass. So this is the Savvy Scout reflector, and you can withdraw the needle entirely. At this point, the measurement that we give the surgeon is the distance from the depth of the skin to where the Savvy Scout is, which in this case, I think was about 1.5 centimeters. And so that helps the surgeon to know this device is not too deep in the breast, and then they know when to start taking the tissue. The procedure for a Savvy localization by mammography is similar to what we would do if it was a wire localization. So you identify the area that you're going after. You've identified that it's best approach, in this case, from superiorly. So you place the patient in the paddle, and then you place your, oh, that's terrible. You place your crosshairs, which in this case is about E1/2 and 8.5. So then you place your device completely superimposed over those crosshairs. And then you go to the orthogonal view, make sure that you're lined up appropriately with that device that you are localizing, with that clip you're localizing. You deploy your device and you can completely remove that needle. And then you label your images for the surgeon. When patient goes on to surgery, they have the specimen radiograph. In this case, you can see that the clip here and the Savvy Scout reflector are been completely removed. And then you can take a look at the margins to see if any of the margins seem to be involved by tumor. Radioactive seeds are similar to the Savvy Scout device. There's different lengths of radioactive seeds. Each of them houses that tiny seed centrally, and there's a probe with a detector that tells you when you have reached the device. So these are 5 millimeters in size. They can be placed in the breast up to 5 days before surgery. And there is no depth limitation. It doesn't matter how far from the skin that mass or that abnormality is, you can still place this. And they're quite cost effective, all things being told. They can produce clear surgical margins in about 74 to 97% of patients. So they're also very effective. Radiation seeds, however, have a lot of nuclear regulations because this is iodine 125, which is radionuclears, radioactive. You have to have training for every member of the team who's going to be handling these devices. So you have to train your radiologist, your technologist, your OR staff. There's a lot of reporting we have to do to the federal government to make sure that every one of these seeds that is placed is actually eventually removed and is disposed of appropriately. If a seed gets lost, or if it migrates in the breast, it is a reportable event. It's quite a mess in trying to track it down. They have to be returned to nuclear medicine from pathology for safe disposal after they've been removed from the breast. So there's actually quite a bit of headache with this. And this is why, for example, at my institution, we've mostly moved away from using these radioactive seeds. And they have to be removed about 5 days after they're placed. So if you were to place that seed, they have an OR date 5 days away, and then the patient were to get sick or the surgeon had to reschedule. Again, it creates a lot of issues to report to our regulating bodies about why this wasn't done within guidelines. So radiation seed placement is very similar to what we've done for all the other devices, right? So here's the lesion of concern. We go ahead and place our needle containing that radioactive seed, we place it into the area of abnormality, and then we deploy that seed right here, and we completely withdraw our needle, and then all that's left is that seed sitting in the breast. You can now detect it with a probe. So once that's been placed, you can see the seed is very, very tiny. Here you have a seed, you have a clip in the breast. The post-procedure imaging helps the surgeon to kind of see what it is that they're going after. And then we'll sometimes draw, depending on the surgeon, we'll also make a paper drawing kind of describing the approach that we used. You know, we have a mass at 2 o'clock, 6 centimeters from the nipple. We place a single seed. And here's an ultrasound kind of demonstrating exactly what we did. This is the depth between the skin and the mass. All of these are just various ways of communicating with the surgeons about what we've done prior to that specimen radiograph. Here's an example of an axillary lymph node that was abnormal. It has a biopsy clip in it, and we went ahead and localized it with a radiation seed as well to aid with targeted dissection. And here in the axilla, you can see the clip and you can see the seed to help the surgeon go after that area. And again, this is something we cannot do with the wire localization. At least we have more concerns about safety with wire. Magnetic seed, again, is very similar. So here's a single device. This is made by Endomag with a very tiny seed that lives inside of it that you can deploy into an area of concern. It's made primarily of stainless steel. It is 5 millimeters, so it's very small. After you've placed it in the breast, you actually induce the magnetism, and then you use the console to detect audible feedback, and it gives you a numeric value of the field strength to tell you how close you are or how far away you are from the magnet. There's a clear surgical margin rate of 83%. It is one of our smallest non-radioactive localization devices, which is great. However, it creates the largest signal void on MRI, which is problematic because so many of our patients will still need an MRI. The other big issue with the magnetic seeds is that you need special surgical instruments that are non-ferromagnetic, because a ferromagnetic surgical instrument interferes with the magnetism of the seed. So having to purchase not just the seed and the equipment, but having to switch out your surgical instruments becomes problematic. So these seeds are also incompatible with the patients who have pacemakers implanted or implanted chest wall devices. That becomes a concern because of that magnetic field. There's a depth limit. You shouldn't place them in a depth in the breast greater than 4 centimeters. And then, like I mentioned before, non-ferromagnetic surgical tools will need to be used. At the tip of the magnetic seed is a tiny bit of bone wax that they use in the formulation, and some patients have complained about an allergy to that. The radioactive, the radiofrequency ID tag are unique. So each radiofrequency ID tag is about 9 millimeters. Each patient has their own unique identifier. There's radio waves that transfers the information, and they're made in a ferrite rod that's wrapped in some copper. And they produce an audible signal as well. These have a 3 to 6 centimeter range in which they can be placed. The cautions are that it creates a very large susceptibility artifact on MRI. There used to be a lot of issues with migration of this radiofrequency tags after they were placed. And so they placed an anti-migratory sheath now to the end of them, so they're less likely to migrate in the breast after they're placed. But otherwise, there's no real known contraindications to these. They are not approved for placement in lymph nodes, which is just something else to consider. So here are some examples. Here's a picture from one of our articles about all of these different devices. And basically, to summarize, I'll go over what are the advantages of non-wire localization. Well, patient comfort is a big one. Patients report very high levels of comfort, especially with the Savvy Scout technology. And the patients prefer to be able to have their scheduling at a different time than when they have their OR date, because typically they have to come in without having eaten anything prior to their breast surgery. And so it makes for a very long day. They have to come in at 6 a.m. to radiology to place a localization device and then wait until noon before they even start their breast surgery. It means it's a very long day. They're very hungry. So having their non-wire localization done on a different day means that they can then have earlier surgical times, which is very comfortable for them. For the patients who've had a wire placed before, they much prefer to have one of these devices that's completely within the breast, because that for them is easier. It's less stressful having a wire than having a wire sticking out. There's a lot of surgical flexibility. When you place a wire into the breast, the surgeon is almost forced to go down the path of the wire that has been placed and then take out the wire and tissue. When you've placed just a seed, the surgeon can go with any approach, really, caudal, inferior, medial, to be able to remove that device without having to remove extra tissue, without having to be forced to take the exact path that you used in placing that wire. There's a lot of scheduling flexibility as well, like I've already discussed, and then you decrease the removal of non-target tissue. And of course, the non-wire localization devices allow for targeted axillary node dissection. And there's improved cosmesis has been reported as well using the non-wire localization devices. The disadvantages is that they cannot be repositioned after they are placed. There's no real MRI guided placement. You would have to go to MRI, place a biopsy marking clip into the breast, and then take the patient up to mammography to do a mammographic wire localization. You would have to also be careful about spacing the devices and bracketing, because remember, when you place more than one device on the same breast and in close proximity, each of those devices can now give an audible signal. So if those devices are put too close together, the signals overlap. And so it becomes very difficult for a surgeon to be able to detect it. So if you are bracketing using a non-wire device, you have to have very clear communication with your surgeon to make sure that these devices are far enough apart that the signal from each of these will be discrete and they can be identified specifically. The device depth for magnetic seeds and for scouts is something to think about, right? Being able to place something only 4 centimeters or only 6 centimeters deep in the breast. You have to keep that in mind for patients with very large breasts or very far posterior abnormalities. But in most cases, we can usually work around the device depth by placing it in a way that when we reposition the patient, you can get the signal needed. So in summary, there are various localization techniques that are available. Wire localization is definitely very safe, it's very accessible, it's very cost effective, but the non-wire localization techniques are also shown to be quite effective, and they're developing to really address some of the disadvantages, the few disadvantages that remain with wire localization. So here are some of my references, and here's my contact information. And I want to go ahead and check on the questions to see if there are any questions.